Okay, good afternoon, everyone in the Eastern time zone, at least where this seminar originates from. I'm sitting on the West Coast. My internet's a little glitchy, so bear with us. And Adrian Fu-Berman is ready to jump in if necessary. This is the weekly seminar series of the Health and the Public Interest Program, which is a program designed to emphasize and educate in areas of non-medical influences on health, things like poverty, social determinants of health, healthcare disparities, pharmaceutical marketing practices and the like. And we're in our 6th year in this program. If you're interested in the program, we'll put the URL in the chat. It's simply hapi.georgetown.edu. So feel free to look at our program and find out more about it. We have information sessions on a regular basis this time of year. So this is a great honor to be bringing you Kelly Clark today, an expert in the area of addiction treatment, and she's going to tell us about current issues in that area. Before we get to that, I want to tell you what the seminar procedure will be today. We'll be starting in just a moment with a formal introduction by Dylan Shapiro, one of our students. And then we'll move into the actual seminar, which we ask that, Kelly, that you keep it to around 45 minutes in length. And then, so Dr. Clarkson will speak for that period of time. And then we'll go back to Dylan, who will moderate the Q&A session, and that will be students first and then followed by outside guests. And anybody is welcome to put anything in chat at any time, but we do ask that when we get to the Q&A that our students unmute and ask the questions directly for us to all hear. So welcome everyone, and I'm really looking forward to this. And Dylan, I'm sure you got a great introduction to start off with.
All right, yeah. Thank you so much, Dr. Myers. As he said, my name is Dylan Shapiro. I'm an undergraduate student in the College of Arts and Sciences studying government. And I'm really excited to welcome today Dr. Kelly Clark, who's going to be our speaker. Dr. Clark is one of the nation's leading experts on substance use disorder and has been invited to testify before the FDA, the Civil Rights and Criminal Divisions of the DOJ, and the National Association of Attorneys General, among a number of other organizations. She works actively across the medical, scientific, criminal justice, and business communities to transform addiction care into evidence-based, cost-effective practice. Dr. Clark serves as a leader in the National Academy of Medicine's Action Collaborative on Countering the U.S. Opioid Epidemic, and has served as a contributing consultant to the recent Opioids in the Workplace, an employer toolkit for supporting prevention, treatment, and recovery with the Kentuckiana Health Collaborative. She has also founded Addiction Crisis Solutions, where she remains president, which does work to improve the quality and affordability of addiction treatment. Her talk today is going to be about waste, fraud, and abuse in addiction treatment, which I'm sure she'll provide a really valuable perspective on. So thank you so much, Dr. Clark, and I'm excited to hear your talk. Welcome, Dr. Clark.
Well, thank you. I am going to do a share screen now, and hopefully you can tell me what it is you're seeing to see if I've got the right thing up. Are you seeing the...
Yeah, but we have the top bar showing. So yeah, there you go.
There we go. Okay, terrific. Okay, well, thanks. I appreciate the opportunity to speak with you all today. I am going to talk, since I'm talking about fraud, waste, and abuse in addiction treatment, I'm going to start by talking about addiction and treatment and addiction treatment in the US. And then to understand fraud, waste, and abuse, you need to understand payment mechanisms and how insurance payment works and what fraud, waste, and abuse are. And I'll give you an example of how a well-intentioned health policy opened up the floodgates for patient abuse as well as fraud, waste, and abuse, and then talk about a little bit about what's being done about this. So my caveats are I'm going to speak from a high level, and my slides are ugly. They just have words, words, words on them. So the underlying issue, the underlying problem is that our country is without an adequate evidence-based professional addiction treatment system. And I'll talk through this as I continue to talk. We have an inadequate number of providers who are actually trained clinically, trained in evidence-based interactions, and we rely on staff which don't have qualifications that we demand out of those in the rest of our medical care system, including our mental health care system. What we have is it relies too much on outdated treatment models, and there's a just gross lack of transparency, quality, and oversight. Just to give you an understanding of how little we have in the way of an evidence-based treatment program, Congress appropriated billions of dollars to help deal with the opioid crisis that had to be sent toward evidence-based care. And hundreds of millions of dollars just sat there because we don't have an infrastructure through which to deploy those dollars. Okay, so think about that. When we think about addiction, we think about a chronic brain disease. So chronic, of course, means we don't look for a cure. We look for managing over time. We need a holistic approach to help people manage their chronic disease. Brain always involves stigma, epilepsy to schizophrenia. And disease means that a medical approach can be effective for treatment. And our outcomes of managing any chronic disease are what we would call decreased morbidity and decreased mortality, or decreased health effects from the chronic disease and decreased early deaths from it, as well as improved functionality and decreased total cost of care. So we're trying to manage, but in our country, our care system was fully isolated outside of the medical system. It was self-pay or grant funded, and there was therefore really no accountability for either process measures or outcome measures. And think about what disorders we continue a primary treatment to just get a bed, right? That's absurd. We came up traditionally through this 28-day sort of programmatic services, which is really what would be paid for in the state of Minnesota. And so if you think about what we've traditionally done for addiction, it would be like a person with a high blood sugar so high that they go to an emergency room, inpatient for 3 days, 28 days of inpatient to learn diet and exercise, and then 2 weeks of follow-up with, counselors and diet groups, right? This is an absurd approach, but that's what we have inherited in the US. So how medical care is supposed to work, and again, we're talking about treatment here. So person's got a medical issue, they go see their physician or other provider. The physician assesses, gathers information, assesses it, comes up with what seems to be a working diagnosis, an initial treatment plan. Maybe more information is needed. The patient then works that plan if it involves medications or counseling or other kinds of supports. And then patient comes back, the information's gathered about how well that's working. Maybe more information is needed. Maybe there's a change of diagnosis and treatment plan. Rinse and repeat, right? This is how medical care is done. And when we're dealing with chronic disease, then we want an individualized treatment plan based on structured best practices, using a biopsychosocial approach. And that involves having the right kind of provider with the right treatment modality in the right place at the right dose for as long as needed at a specific point of time during the course of that disease management, right? Makes sense. So when we come to right providers, there are independently licensed providers like physicians, master's level psychotherapists, and doctorate level psychotherapists, and advanced practice clinicians who are nurse practitioners, physician assistants, have prescribing capabilities. Okay, these are independently licensed providers. Okay, then we've got providers who are not able to function independently as licensed providers, like nurses, registered nurses, or counselors or care coordinators. They may be licensed, they may be certified, but they don't provide services that are really able to be reimbursed as medical services independently of those licensed providers or programs above. And then we've got non-clinical and ancillary support providers like care coordinators or peer supports or last and master's degree social workers and so on, or 12-step meetings, which are not treatment, they're mutual support meetings. When we talk about right place, there's inpatient, which means a person sleeps in the treatment facility. So those are acute care hospitals or nursing homes or rehabs, chronic hospitals, or there are outpatients places, which means the patient doesn't sleep there. So that means you come and see your doctor or physical therapist or whoever in their office, or their structured treatment programs like cardiac, respiratory, or drug rehabilitation programs. For behavioral health, there are intensive outpatient or partial hospital levels of care. So 3 hours a day, 3 days a week is a intensive outpatient. Partial is 20 hours a week. Paying for somebody's housing when they're an inpatient, when they're an outpatient, that's an inducement for them to engage in that treatment, and that's not allowed. So right provider, right place. But this is our healthcare system. Okay, so we have wellness things, which I have over to the left. Those are your meditation apps and gym memberships and those kinds of things. And then we've got healthcare services. And we have broken these out in this country into physical and behavioral healthcare services. And then we have broken behavioral healthcare services into basically substance use disorders and mental health. And there is an enormous silo between substance use and mental health, which many people don't know. I'm a psychiatrist. Okay, 4 years of medical school, 4 years of residency training in psychiatry. Of that time, how much time did I get in treatment for substance use disorders? 2 months out of 4 years of psychiatric training, and that has since decreased to 1 month out of 4 years. Okay, most mental health providers don't treat substance use disorders. They just don't treat them. They will refer them to a different system. Okay, this is siloed by payment. This is siloed by licensing, by credentialing. This is siloed by oversight. It's an enormous silo. So when you hear people talk about mental health, just assume they're ignoring addiction unless they're proven otherwise. So back to right place, something called the ASAM criteria, and there's a new version of this out, like literally in the past month. But it does 3 things. It goes through and it gets information, and it becomes a patient assessment tool to help determine where the patient is and what they need at that point in time. And it's used to match patients to the appropriate level of care based on how severe their disease is at that moment. And in order to match them to the levels of care, it has to define those levels of care and establish what that continuum of care is. Okay, so these are national ASAM guidelines that are used by a lot of payers to determine level of care payments. Okay, but there's a lack of national standards for licensing addiction treatment levels of care. So substance use disorder levels of care are licensed by states totally idiosyncratically. Okay, so what we see are in most of the people who are actually delivering care in these rehab, inpatient, intensive outpatient, partial hospitals, in most of those levels of care, most of the people who are delivering care are not professionally capable of performing psychotherapy. They're not individually licensed. Okay, and so since general outpatient mental health doesn't deal with addiction, what happens is addiction care is pushed into programs which bill at a day rate for general counseling services, watching a movie and discussing it, and etc. Okay, that's what the actual treatment looks like. And it's so idiosyncratic, I would say that, so for example, New York State has got a partial hospital level of care for mental health. They don't have one for substance use disorders. So if your primary diagnosis is alcohol use disorder, there is no partial hospital program you can go to because the state doesn't recognize it. If instead we say your diagnosis is major depressive disorder, then you can go to the mental health partial hospital level of care. That's our level of siloing. Okay? So where's the transparency? Where's the oversight here? Well, we've got 2 large organizations called the Joint Commission, or CARF, which is accredits rehab facilities. And the way those work is, if you're a treatment organization or a facility, you pay one of those 2 to come to your facility, and they will absolutely look to see if your fire extinguisher is still valid, or if it's expired. But they will not look and see if your medical care is appropriate, because that's not what they really look at. Okay, if you don't like what CARF said when you've paid them to come and certify you, you can, in the next year or 2, decide to pay money to the Joint Commission to come and do your certification evaluation. So as I say here, gee, can you spot any conflict of interest here? Okay. So transparency and oversight. Payers, by which I mean what you think of as health insurance plans, may make programs in network or not, but payers actually generally function as the grown-ups in our medical system. But in general, substance use disorder treatment is the Wild West medical care. Most treatment programs for addiction don't provide baseline quality of care. This is not up for debate. They don't. No one's demanding that treatment quality be the same as for other diseases. We have legacy treatment programs that we know are doing what doesn't work or is actually harmful. And there is no way for patients or you or payers or policymakers or anyone to actually know what care is actually being able to be delivered by a certain program or how well they deliver it. Okay, so that's our background here. That's our background. Now let's talk about paying for medical services. Medical services get paid for in different ways. Okay, so there may be grant-funded provider groups, like, and I'm going to say VA hospitals are like that. They get a chunk of money to take care of a chunk of population. There are community health care centers for medical and behavioral health care that get chunks of money for grant funding. Okay, unlike the VA, grant funding for other care is more erratic. Okay, but that's one way medical services are paid for. In general, we have a fee-for-service payment system, and that means that, say, the doctor sees you in the office and gets paid for that visit. Okay, a service is performed, a fee is paid for that specific service, whether that service is a day in a partial hospital program or a nursing home, or whether that service is an appendectomy with the services that were provided by the surgeon, the anesthesiologist, the hospital, and et cetera. The pharmacy, all of those pieces, fees for specific services. We have an aspirational value-based approach where you get X amount of dollars to take care of a bucket of some population's healthcare needs. So not all of their needs, but some kind of them. In the behavioral health area, this is infantile. We are nowhere near doing things here that we are in other parts of healthcare, which we can discuss if that's of interest later. Another way to think about payment for medical services is there's self-pay, which is called cash, but it's really self-pay. And this is particularly true for behavioral health providers. There's nothing intrinsically wrong with paying for a service that you receive. We see this in other areas as well, like cosmetic surgeries, or if you want to get a high-tech intraocular lens when you're having glaucoma surgery, you would have to pay for that higher quality lens. Okay, there's nothing particularly bad about this, but this is a way that care is paid for. Then there's something that we think of as classical healthcare insurance, by which I mean straight Medicare is another name for it, or fee-for-service Medicaid. And here the care is not managed. The plan pays a rate to anybody without negotiating the rate. So Medicare or a fee-for-service Medicaid will put up, this is what we pay for that appendectomy to the anesthesiologist. This is what we pay to that surgeon. This is what we pay for an office visit to your doctor. Okay, it doesn't matter what you bill. There's no as a provider. There's no negotiation. This is what's paid. Okay, so insurance just takes that risks and pays out those claims. Now there are some case rate bundled rates that exist, but in general, again, it's for, this is a piece of service and it's going to have a case rate with it. And because there's no oversight, there's a huge amount of fraud, waste, and abuse in straight Medicare. And then the other way to really think about what most people think about for payment, they think about health plans or managed care programs, where there can be fee for service or there can be case bundled rates involved here. But almost all commercial insurance works this way. Most Medicaid, Medicare Advantage programs, your employer sponsored plan. So some of you are working and get this through your employer. Some of you are under the age of 26 and get this through your parents' insurance through their employer. Okay, these are typically health plan or what gets sold on the exchanges, the healthcare exchanges. These are managed plans. Okay, so health plans are bought by an individual or an employer, and the plan is managed or administered by some kind of a health insurance company, and I'll call those payers. Okay, these plans are extremely highly regulated. Okay, most employer plans are self-funded. Okay, by that means, so say you're Georgetown, you are employed by the university. Okay, you have a health plan that the university bought on your behalf, and they pay a chunk of on your behalf, and then they selected a health insurance company to administer that plan. Georgetown itself holds the risk for that plan. So any of the monies that are being spent for your medical care are not, quote, coming out of the pocket of the insurance company. It's a self-insured plan. They're coming out of the pocket of Georgetown. Okay. The insurance company, its fiduciary responsibility is to administer the plan as exactly as possible, trying to make sure that it pays for what it's supposed to pay for and does not pay for what it's not supposed to pay for. It is administering that plan that was purchased, and what's covered by that plan is covered in that plan language. So what is covered by a health plan is delineated in that plan language. The interactions and the requirements for each party regarding billing and payment under health plans, so that means the payer, the plan members, the providers, the plan purchasers are all described by that plan and payers in their documents and protocols. Okay. Health plans don't cover what a member may want or may potentially be helpful, but only cover what's medically necessary. So, hey, it may be helpful for me to get a massage every week. I might want to get a massage 3 times a week, but it may be medically necessary for me to be getting massage after, say, a surgery for a certain number of times. Okay, but not because something might be helpful or might want it. It has to be medically necessary for the plan to cover it. And again, that health insurance company, that payer, has an obligation not to pay for uncovered services because it's not their money typically, right? It would be Georgetown's money, and to pay for the services that are covered in there appropriately. That's what was purchased by Georgetown, that plan, on behalf of its employees. So what's medical necessity? Medical necessity is a medical legal construct. It's fully defined in each patient's health plan documents, the contract between that purchaser and the health plan. Okay, there are specific state and federal requirements in each kind of health plan. And again, medical necessity is specific to the contract of that person, that member of the plan that's covered. But in general, the basic principles of medical necessity are that something is medically necessary if it's for diagnosing, treating, and monitoring a medical condition, clinically appropriate and consistent with generally accepted medical practices, not primarily for the convenience of the patient or providers, not more costly than equally effective alternatives, and in the least restrictive setting. Okay, so those are the general constructs that go into medical necessity. So if a provider provides a service and they believe it's a covered service by that health plan, which has a multitude of different pieces to a covered service, what's listed in their plan, sometimes they don't know something's covered or not. But if they believe it's medically necessary, then they can legitimately submit a claim for payment. Okay. The claim will include information, right? Who got the care, what care was delivered, where was the care delivered, when was the care delivered, by whom was the care delivered, and the amount that's being billed for that care, and the diagnosis for which that service was rendered. right? If I put in a bill as a psychiatrist for an appendectomy, that's going to get kicked back. Okay, that doesn't line up. Okay, so all of those pieces of information go into a billing claim. Now, health plans, usually through their insurance, their payers, they delineate. Well, the health plans itself delineates what providers are in network, what providers are actually covered by the plan. Okay, and then that network is contracted. These providers are contracted with the plans, typically through the payers. And these are contracts that agree upon rates for specific services. So I agree for whatever health plan, Georgetown has bought for you, that if I see you in office for a specific visit, that I will be paid X number of dollars, contracted. Okay. These are the services I will deliver. These are the rates at which your health plan, your health plan is going to be paying this through the payer who administers that. Okay. We're all contracted. Some health plans have no out-of-network benefits at all. Okay, so if somebody's not in network, they don't cover anything that other provider is going to perform or provide. Sometimes, and this is typically true with commercial plans that can be chosen when you choose what you're buying. They'll have parallel benefit structures, so there'll be coded deductibles and co-insurance and et cetera for in-network. And then there'll be some kind of co-payments, co-insurance, deductibles, something for out-of-network that parallel. Okay, so there's that negotiated payment amount. That's why when you get your bill and you see something like the hospital billed $10,000 for that appendectomy, but the negotiated rate was $1,000, and your copay was $50. That's because they were in network. They contracted that. That's what's the way they decided. And as part of contracting, you, the patient, are held harmless for all of that chunk between they billed $10,000, but their negotiated rate was, say, $2,000. That $8,000 in between, you don't pay that. Nobody pays that. Okay. So the network provider is a way to help that member not get exorbitant costs at the end of after something service has been delivered. Okay, if that provider is accepting Medicare or Medicaid assignment, or if they're an in-network provider, they can bill anything they want. They are going to be paid the amount that they have agreed to accept. Right? If you bill Medicare $10,000 for an office for a pregnancy test, you're going to get paid the $15 that they pay for every pregnancy test. It doesn't matter. And the patient doesn't have to pay any of that difference. Okay, that's in network. Out of network, there's no contract. There's no agreed upon rate. There's no ongoing relationship with the parties for quality oversight and et cetera. Okay. So if you look at maybe some old plans that some of you might have, they would show you that these commercial health plans might cover out-of-network services with some percentage of charges after their deductible. Okay, the system of paying a percentage of charges, just charges, by an out-of-network provider facilitates fraud and abuse to occur. Okay, so what are fraud, waste, and abuse? Fraud is basically intentionally or deliberately acting by deception or some other unfair means to get somebody's money here, we'll say. Okay, healthcare fraud. Okay, it's intentional and deliberate. Say I have not seen you in a month, but I decide to bill you for weekly sessions, and I know I'm doing that, and I hadn't seen you. That's fraud. That's intentionally billing. Waste and abuse are basically not done volitionally. They can be errors. Say my billing company got confused. They couldn't read my handwriting. They took the wrong date down. Okay, that could be a problem there. But if I were, for example, seeing you every day and saying that was medically necessary as an outpatient to treat, your something that's not going to be necessary, or I'm getting a pregnancy test on you every day and billing for that, that would be waste and abuse. Okay, and these are definitions here from CMS. These are federal kinds of definitions, but this is how things are generally defined by all plans. Okay, and in fact, the difference between waste and abuse have blurred into sort of one construct recently, but you will typically hear fraud, waste, and abuse. So I put this in now. So billing for care not provided, providing medically unnecessary care like pregnancy tests every day, routinely waiving your co-payments and your deductibles, that's fraud, waste, and abuse. If you're looking for easy ways to find billions of dollars in fraud, you would look at addiction treatment, including urine drug testing. You'd look at genetic testing. You'd look at compound pharmacies and durable medical equipment. These are just huge buckets where there's billions of dollars in fraud, waste, and abuse. And now let's look at something that really drove fraud, waste, and abuse in addiction treatment, which was HAPACA, the Patient Protection and Affordable Care Act, otherwise known as the ACA, otherwise known as Obamacare, depending on your political persuasion. And so what was part of this is that this act passed in 2010 and really became functional about 2014 is when it kind of phased all in, or mostly phased in, is that it allowed the children of employees to stay on their parents' employers' commercial insurance until they're 26. So that was item one. Item two is that it defined mental health and addiction care as essential health benefits, and it sat upon earlier kinds of parity acts. So remember what I said earlier about we don't have an adequate treatment system. We don't have appropriately trained numbers of people or quality or oversight. Now we have chunks of money coming primarily from the commercial healthcare sector that can cover this treatment. So let's talk about urine drug tests. Some of you may be aware of this, but I'm thinking probably not. Also, urine also called liquid gold. So let me give you this assumption. An addiction treatment program takes urine from every single patient 3 times a week, and they send it out as an out-of-network provider, and they bill $4,000 for this urine test, which may cost them $50 to do, but at any rate, it's not medically necessary to test everybody 3 times a week in perpetuity, okay? And certainly not appropriate to be submitting for $4,000 as an out-of-network provider. If you're an in-network provider and you bill $4,000, you know what you're going to get. You're going to get your $200. You're going to get your $60 from Medicaid. You know what you are going to be getting because you've contracted for it. Doesn't matter what you bill. Okay. Commercial plan in network, a couple $100. Medicaid, substantially less. Okay. Medicare in the middle, but they'll put some limits on it. Okay. If a commercial plan had been paying an out-of-network provider 80% of billed charges, that means they're paying $3,200 for that urine drug test. So for one single patient over a year, doing this average math, that provider could get $35,000 if they were commercial in network. If they were billing Medicaid, they could get $15,000. If they were billing your mom and dad's Blue Cross Blue Shield, they could get $500,000 doing these grossly unnecessary urine drug tests on one person over 1 year. So now you might be saying, I don't know, Kelly, how big of a problem was this? Well, this is so big of a problem that by 2016, might have been at the end of 2015, ASAM, which is the organization, American Society of Addiction Medicine, where I'm a past president. This is the organization that represents the addiction doctors of the country, put out an entire drug testing document. And one of the reasons this was done is because of this inappropriate drug testing with these extraordinary costs to third-party payers, taxpayers, and patients. And it's leading to loss of credibility in the addiction treatment field in general with these large test panels, I mean, of tests that are not medically necessary. I mean, really, do you need to test for nicotine 3 times a week in someone's urine? No. The frequent testing, and then using very expensive, highly technical tests on everything. Okay. So one of the purposes was to try to decrease waste and abuse. It is, I will just tell you, it's very rare for a medical society to put out a document because they're afraid of fraud, waste, and abuse in their area of expertise. Okay, that's how big of a problem it was. So the federal government, state governments, plans, a variety of folks, a part of this healthcare fraud prevention partnership in 2018, examined clinical lab services, and really their primary focus here was on fraud, waste, abuse, on urine drug tests of all the kinds of testing they were looking at. Office of Inspector General of Health and Human Services, looking at Medicare. They showed an overpayment rate for these definitive tests, these expensive tests for large numbers of kinds of substances to be about 71% of improperly paying for that. Okay? The way that the language for drug testing was changed by CMS, by Medicare in 2015. They changed the way in which tests were coded and the kinds of bundle tests they would pay for because of this, because it was a multi-billion-dollar issue for commercial insurance. Okay. Okay, so that's just urine drug testing. Well, let's talk about some other areas where we're seeing fraud, waste, and abuse. In the Medicaid area, now Medicaid pays such low rates that generally outpatient providers and private programs don't accept Medicaid patients. Some do, but typically they'll have to bundle in other services, group sessions or counseling, drug tests, to try to put together some kind of bundle, because the actual fee-for-service rates for the medical care is so low. The community health clinics get a substantial percentage increase over Medicaid rates in order to help kind of keep them afloat. But in general, unless it's the community health program or like a hospital that has to take Medicaid, in general, and particularly in behavioral health, the rates are lower than what it costs to provide the care. But attempts to do bundle payment, this is a way that this is kind of a quality metric for people that are trying to provide the care in a way that doesn't put them under, that still makes them a profit. And by the way, just so you folks all remember, for-profit means that an organization pays taxes. Nonprofit means an organization doesn't pay taxes. There is no moral code here. This is simply a matter of who pays taxes or not. Okay. And if you don't know about GuideStar, I love nonprofits because they have to show their taxes, and you can look up and see how much your deans make and the heads of your hospitals and your highest paying folks. So if you think nonprofit is sort of moral superior and for-profit is not, you're misunderstanding the tax code around them. So some state payer specific fraud, waste, and abuse issues might be the way Medicaid is billed. And so billed for things that don't occur, for psychotherapy sessions that don't occur, for days of treatment that don't occur. There's dollars that might be coming from criminal justice budget for court-ordered treatment or for 28-day programs. Those are not medically necessary. And often just the level of staff and what they're doing in those sessions won't meet criteria for codes that are billed. Now I want to talk about the Florida Shuffle, which some of you may have heard of, but I think it's important to understand here. And let me just try to see if I can. Okay. So am I still sharing my screen? Now I'm not, right? Okay. So let me tell you about the Florida Shuffle, because it's important to see how some of this is played out. And by some of this, I mean just the Affordable Care Act. I mean policies that were put into place to try to, quote, get people help, or make sure that, providers are paid, or etc. Okay. So the Florida Shuffle is the name for a group of protocols and processes that happen. And they were focused in Florida, although they are, in California, the states where a lot of people might like to go to. And as things have been shutting down some of this in Florida, they moved to Georgia, they just move up to other states. Okay. But this is what happens. Okay. You can see the kind of money that could happen with out of network for urine drug tests. So how are you going to get all of that urine? Well, you need the bodies to provide the urine. And since, again, the ACA meant that substance use disorder was an essential health benefit, and there's not adequate oversight, training, anything for this area, this is what happened when all of that money became available. Treatment programs in Florida hired body brokers, which are individuals who are paid for every patient body they deliver for admission and or staying a certain amount of time in a treatment program in Florida. Programs would fly people down from whatever state they were in, because, hey, if you're in Iowa and it's, January, and you have the option to go to Palm Beach, on the beach in Florida, and then someone's going to pay you a plane ticket, and your family would love for you to go away and get fixed, those are the people who ended up down there. People between between the ages of 17 and 26, typically, because they were on their parents' insurance. They would often be given alcohol or drugs prior to admission, so they would test positive on a screen. I say would, they are often given drugs before they're admitted, so they test positive on a screen. Okay. They're homeless, they're unemployed, they're covered by their parents' commercial insurance. Okay. They're admitted to detox, whether they need detox or not. Detox is actually something, withdrawal management, that we need when a person's physiologically dependent and they need to be medically managed to stop something. So if you're just, use one day, you don't need a, quote, detox. Your body doesn't need that. Right. But they were admitted there. They were often given intoxicating substances there for, quote, their withdrawal or their post-acute withdrawal, or for helping them. So often large doses of drugs that could make them sedated, even dependent on the treatment kind of program. They would then be stepped down into a kind of, quote, unquote, rehab, or into what they have in Florida, which is a partial hospital plus community housing. Or they would be, from there, they may be stepped down into outpatient, straight partial hospital, or intensive outpatient, or outpatient, often being sent to an affiliated sober home. Sober homes are not treatment programs. They're supposed to be places where people can live free from drugs and alcohol. And so sometimes those sober homes, they're not regulated. Right. So sometimes those sober homes had 20 beds, but they had 25 people staying there a night, literally sleeping on a sofa. Okay. And as long as the patient was showing up to their IOP or partial hospital, that partial hospital or IOP would pay for their rent every week. Okay. And all they had to do was show up to the partial hospital or the IOP, where they were billing $2,000, $3,000, $4,000 per day for treatment, which might consist of that person spending 3 hours literally sleeping through a group session, or being in a group where there was physical violence, or being in a group where they were just watching a movie with everyone cross-talking, run by people who are not capable clinically of performing psychotherapy, not psychotherapy groups. These are structured, maybe psychoeducational, maybe supportive kinds of groups, but because they didn't didn't need to do licensed folks, most of that would be just provided by people who had maybe no training. Maybe they had associate's degree. Maybe they had a high school diploma. Okay. And along with this could come urine testing. So if the person's at the end of their 28 days and they are testing positive for drugs the whole way along, never discussed with them or rarely discussed with them, but not particularly acted on, there would suddenly be, oh, look, they're positive for drugs. They need to be discharged from our rehab IOP partial and go back into our detox. Rinse and repeat. They'd be admitted with their romantic partners who may be physically violent. They may be prostituted. They may be selling drugs. They may be employed very quickly upon, quote, graduating as an employee of these, quote, treatment centers. Okay. And there's no legitimate treatment planning, because the whole point when they leave is to go into another sober home from which they would use drugs and go back in, round and round and round. So obviously the patient harm is that they are in what we call counter-therapeutic or contra-therapeutic programs, where they're not only going to not get better, they're going to get worse, right? They may be absolutely just abused through prostitutions, not having a bed to sleep on, and really undermining any clinical impulse to use. And this encourages them to remain engaged in this sort of program dependent lifestyle until they turn 26, and then it's over. They don't have insurance. They're out. Okay. The other thing that happens is that as these enormous out-of-network bills come in, these are unemployed homeless people, right? They don't have the ability to pay $30,000, $50,000, $60,000 a month of these bills that are sent off. All right. So often the fraud, waste, and abuse is that there's no intention of the facility to ever actually collect the patient due part. Or if there is an intention, or if they're sort of caught with this, they, and more likely their parents, receive these bills for these astronomical amounts. So that's what the Florida Shuffle is. Now, what I just gave you are examples of many elements that can go into the Florida Shuffle. Doesn't mean that any one place engaged in all of those or specific combination of those, but those are the kinds of elements that we see in what's been called the Florida Shuffle. Okay. And there isn't oversight here. Okay. The states license, and they very rarely provide any kind of oversight. They'll often say, oh, you've gotten a Joint Commission or CARF accreditation. That's good. We'll license you for a few more years. Right? There really is not oversight. The closest thing to oversight may be the health plans, but think about what health plans have to do. The insurance companies that administer this, they get millions of these claims, right? Our billing is a trust-based system, right? We don't anticipate that there's going to be a $10,000 bill for a pregnancy test. We don't anticipate the pregnancy tests are going to be done 3 times a week on every woman in perpetuity, right? Systems aren't built for that. You literally have to build your computer algorithms to look for this kind of stuff. Okay. So we end up with some isolated cases of state and federal criminal charges or civil charges. Every health insurance company has got a special investigation unit that looks for fraud, waste, and abuse. But in general, we're a bit stuck in this area right now. And we're just trying to play whack-a-mole with some of these, but there are probably still thousands of organizations engaging in this level of fraud, waste, and abuse, all sort of opened up by this concept that people should be able to access treatment without the same restrictions we have on any kind of treatment, which is that people should not be able to access bad treatment or treatment that harms them and should not be paid for that. But we've isolated this over for so long. This is what we have. Now, I know I'm over my time, so, well, if I had 45 minutes, I'm right at my time after intros. So I'll stop so we can have some discussion. But I just wanted to give that one kind of big view, a high level view of how some, well-meaning attempts to take care of our problem, and we have a big problem with substance use disorder and not enough treatment, doesn't get solved by simply throwing money and saying, here, without building training programs, building certification programs, building oversight programs, educating the market, all of that sort of thing. So I'll stop now, and I'll look forward to our conversation.
All right. Thank you so much, Dr. Clark. So I think Dr. Myers was talking about this a little bit earlier, but generally the way that we'll run these is that HAPI students will get the opportunity to ask questions first, and then we'll sort of open it up more broadly. So if anyone has any questions, feel free to raise your hands, and I think probably just calling on you will be the easiest way of doing things. I also have one, so I'm going to ask.
No questions. I've depressed everyone so much that they can't speak.
Yeah, so I was sort of wondering about you were talking about, the harm that this has on patients, right? And sort of once you turn 26, you're just sort of kicked out of the system, right? And I was wondering, do you know of any work that's happening to sort of try to provide support or help to people who have sort of been kicked to the curb because they turned 26? Like, is that even happening at all in any meaningful way?
Well, they shouldn't have been in that system in the first place.
Yeah.
I mean, that's the problem, right? The way that they will, often they will end up going home to their parents. They will often end up just rotating or continuing to rotate through the justice system because they're continuing their active drug use. I mean, this system just continues their active drug use. So they're continuing with theft and prostitution and drug dealing and etc. And so they're just sort of, they rotate in through the criminal justice system. But the primary issue is that they've been, so for those people who've been trapped in the system for a few years, is that they've been so harmed that it takes it'll take quite a bit for them to go back to where they were, much less where they needed to be.
Yeah, thank you. I see Kundai has her hand up. So.
Thank you for your presentation. My question was, have there been any reports from parents or patients who had been through the system and then, they didn't get better? And then are they able to report this? Is this something that can be monitored so that people actually investigate into this? Has that helped at all? Or are there interested parties who are constantly trying to silence the voices so that they can keep the cycle going?
No, great question. So if you Google Florida Shuffle, you will find a number of really good articles by people who were patients trapped in that cycle. You'll find articles by parents whose children were trapped in that cycle, many of whom have sadly died. There is a sober home task force that the federal government runs that's focused. One is focused around Florida, and one's focused around California. And I've done a number of expert witness cases for the criminal frauds in Florida, but those are one-off kinds of things, right? So there've been, Florida has it moved to change some of its rules around sober homes. Some areas of the state and some counties have focused on this area. I mean, it's considered like a multi-billion-dollar industry in parts like West Palm Beach, that area of Florida. It's there's given that there is not much oversight, the state doesn't send people out really to look over each of these places. Patients don't know what they're supposed to be getting. When they do, they're trapped. And one of the problems is there's no way for anybody to know, here's a picture of something on the web. You have no idea what that is. Patients have no idea what that is. Payers have no idea what that is. That's part of our problem. And so what it takes, the other part of our problem is that we keep trying to say, well, we just need to screen people and have them come forward and get treatment. We don't have treatment. We don't have a treatment system, right? So people will go to whatever they can find, even if what they're finding is harmful. And in order to, quote, report them, what are we reporting them for? Patient abuse. Those could take many years to come to court. And that's one treatment facility. Criminal fraud, one treatment facility. So I was an expert in the Ligotti case, who was charged with $600 and some million of fraud, being medical director of a large number of treatment programs in Florida. He pled, I think, 20 years. But so that, that's one person, right? So what it would take here, you can see, is a multifactorial approach to actually building a treatment system, and then overseeing it, and then sort of rapidly shutting down places that need to be rapidly shut down.
All right, thank you. I saw that Katiana has her hand raised as well.
Thanks so much, Dylan, for facilitating this talk, and Dr. Clark for being here. Really informative chat. I'm actually from South Florida, and while I moved away after the big boom of rehab centers, there were still quite a few back in the early 2000s, and I didn't know anything about the shuffling. So thank you so much. In your ideal world, with money still as a constraint, what is your ideal solution to these abuse problems, and how would you solve the addiction crisis then?
Oh, with money still as a constraint? Well, we have a bunch of money that's coming through from a variety of opioid settlements, and we are wasting an enormous amount of money on treatment that's harmful or useless, as well as these urine drug tests. So there is a substantial amount of money that could be available to tackle these problems if we decided to utilize it for that. So the first thing we would need to do is actually build a treatment system. We need to train doctors, we need to train advanced practice clinicians, we need to train psychotherapists of all types, and move away from, and instead we're moving in a slightly different direction right now, because it's hard to train people. You actually have to build treatment programs, training programs, and you have to build a new workforce. Okay, the workforce we have anywhere right now in healthcare is totally overwhelmed. We cannot use them for any of this. You can't use primary care. You're not going to use, the mental health providers. They don't have the capacity to do this. We need new providers. And what you see right now is a push to use peers for care coordinators and care managers. And care coordinators and care managers are great, very helpful. They're not treatment providers. They're not clinicians. They don't do treatment. Okay, so, but there's this whole push that way. And there's no data that I know of that peers as care coordinators and case managers have any better outcomes than people who don't have the disease of addiction, who work as care coordinators and case managers, right? You don't need to have had cancer to be an oncologist. I don't need, the care coordinator, my care coordinator, to have had cancer. Okay. So we need to focus in on actually building a treatment system. And we need to focus in on building the people who can do this. We need to help the health plans stop paying for care that's useless or harmful, because we're pushing on them right now to say, well, you're not paying for providers. You don't have a big enough network. I can't find anybody around you. Why won't you pay this person? Because this person shouldn't be paid for what they're doing. Right? So the health plans can't contract more providers than exist. So this is a bigger problem, right? The next piece is to turn what we have into actual appropriate treatment. These legacy programs that we have that aren't engaging in appropriate treatment. If they're not engaging in appropriate treatment, stop paying for them and stop certifying them. And that's a political problem. That's a huge political problem, because a lot of these have been around for forever and they're very well politically connected, and they've got ways around, they'll get money from SAMHSA that's supposed to be for, evidence-based care, but they won't allow use of medications to treat addiction, etc. So, those are some easiest steps, because there's nothing easy here. And then the other piece is an educational piece for people, because we've got a society that glorifies alcohol and drug use, and that's a bigger issue.
All right, thank you. So I don't see any hands up at the moment. If any other HAPI students do have questions, please, take the time now. But if not, I think we could probably open it up to general sort of audience members as well, if any of them have any questions.
So while people are pulling their, sorry, I got two devices going here. While people are pulling their questions together, I want to point out that I put an article in the web, which is in the chat, which is one of the ones that Dr. Clark was talking about in terms of patient accounts of the Florida Shuffle. And anyone who's specifically interested in addiction policy as well as practice could look at our sister MS program. And over the course of this seminar series, I'm going to be, over the next couple of years, each year bringing a couple of topics that kind of bridge these two programs, because certainly the HAPI program is very much interested in the problem of addiction and how we address it as a society and what effects it's having on healthcare in a societal kind of way. So turn it back to Dylan after that brief advertisement.
Yeah, so there are a bunch of questions in the chat. I'm not sure if you can see them, Dr. Clark, but it might make sense just to read them just so people know what's going on. So the first one is, could you discuss funding for medications for OUD? Is there FWA in fraud, waste, and abuse in the medication sector, especially from Medicaid?
So yes, there's fraud, waste, and abuse in every sector. Medicaid, when it comes to medications for OUD, I mean, the primary problem with Medicaid members is that the rates that Medicaid pays are just abysmally low. And so providers don't want to typically engage with Medicaid populations. Some will, particularly if they can get work on bundled payments with other things going in their care coordinators, etc. There is a bundled code from CMS that can be used for OBOT, office-based opioid treatment, and there is a bundled code for OTPs, or opioid treatment programs, which is methadone. So those do exist. It depends on which Medicaid would utilize any of those codes. again, the thing with Medicaid is that I can bill you $2,000 for a visit, but the posted Medicaid rate is going to be, $40. So, where there is fraud, waste, and abuse, there are in slightly different areas. They can be around providing services that haven't happened, etc. That's particularly where it is. But it's a real problem in getting treatment providers to provide MOUD, medications for opioid use disorder, to Medicaid, particularly since there are a number of Medicaid, state Medicaid attorneys generals and things looking at this as an area of fraud, waste, and abuse for, in areas where it isn't fraud, waste, and abuse, but it makes a really nice political headline to do that. And so providers are scared. 1 in 7 rural doctors won't prescribe buprenorphine because they're afraid of the government's interference. So that's a real issue. And let me say, Mr. Grogan, I'm so sorry to see this, that your niece died from the Florida shuffle. I have not seen an estimate of the number of people who've died, because it would be difficult to determine, because people die while they're in these, like, physically in the programs, after they've been kicked out of the programs, after they've, gone home without appropriate follow-up, and etc. So I don't have that number, but I'm sorry for your loss. And Ms. Pearson, you have a question?
I can ask my question specifically. I just didn't want to bust in. Insurers, in some cases, have been really good at recognizing they're getting a lot of bills for something that they don't think is medically necessary. And maybe not the first year or the second year, but by the third or fourth year, they set policies in place of, we're not going to pay for a urine test more than 8 times a quarter, say, like that example you had from Medicare. Have any of the commercial insurers, because it does seem like if you cut off that source of money, that some of the worst places would just close up and move into some other line of business, some other way of defrauding somebody.
Yeah, some labs, I think, have moved from urine drug tests to genetic tests, but yeah. So what has to happen for that? So this happened in 2015, 2016, is that CMS Medicare noticed this drug testing stuff. The commercial plans noticed it, and they started to put limits on. But there are a number of different codes for those, and it has to go in. And how they pay and what the limits that they pay and how they determine what they pay is determined through the plans, the individual plans. And then they have to go into the computers, and for each of those, sometimes for each of those plans or for each of those build codes, they have to put different information into the computer on how it's going to adjudicate those claims. And it is a process. It is a long process. And so most of them have issues, things now with their drug testing, I believe. But, looking at high amounts for IOPs or partial hospitals or some of the other things that come spinning out of there can also be really problematic. And they don't know, unless they dig into the medical record with somebody who's really digging into the medical record, whether the things they're being billed for those treatment programs actually occurred at a level that they could legitimately be paid for. So it's an expensive, time-consuming operation.
Thanks.
All right, I think we probably have time for 2 more questions. So there's one in the chat right now. How do you balance fraud, waste, and abuse and investment in combating substance use disorder? Excuse me.
Oh, I'd love to take some of the money that's being spent for fraud, waste, and abusive billing services and focus it on combating substance use disorders. And as and as I said earlier about, well, how would I address this? There is a lot of money on the table, but what we like to do as a society is we like to do like easy things like, oh, we're going to screen and then we're going to refer people for treatment. We have to build a treatment system, folks. We have to build a treatment center. We have to cut down on these scummy operators. And then we have to pay enough to quality operators so that they will want to operate, because this is part of our problem. We're bleeding so much money out into this stuff that shouldn't get paid for, that we're underpaying for quality providers. And that's going to require, frankly, that's going to require the biggest purchasers of healthcare, which are the government and employers, to decide they're done wasting this money, and that their workforce requires this system be in place. And tell the payers it's okay, don't pay for this crummy treatment, and please do pay enough for good treatment. And how can we help in our community where our employees are to build appropriate systems through our universities, through our treatment programs, etc. It's not an easy lift. And no one likes that answer. No one likes the "it's not an easy lift" answer.
All right, I see Dr. Myers' hand is up. I think you're on mute, Dr. Myers.
Still on mute. And still on mute. Can't hear you.
Okay,
you go.
so
Oh, there you
I'm really having trouble getting this thing to work between listening on one and speaking on the other. So one of the big criticisms one often hears in this area is how 12-step programs don't work. And you kind of put this in an interesting light, that those really aren't medical treatment, they're support services. I like that way of looking at it, because we really don't have better answers for a lot of people, or haven't had. Medical assisted treatment is very controversial, and I think early in its days. I wonder if you would think it's a fair thing to say that 12-step programs do work for some people, and that it's not fair to consider them as alternatives to medical therapy or clinical treatment, but as an adjunct, which really can be valuable, but shouldn't supplant more, let's say, clinical treatments when you're billing for clinical treatments.
Yeah, so I was speaking once at the trade organization for the treatment industry, which are the rehabs, and someone said that the people that were staying with them are called guests, and that they used the primary spiritual program of 12-step. And I said, if you are providing a spiritual treatment, bill under the spiritual benefit. If you're going to bill under the medical benefit, you need to bill for medical care. Okay, and that is defined. So when we think about 12-step, that is a spiritual program. And most people, when they say 12-step, they really mean like AA meetings. They mean mutual support meetings. And mutual support meetings can be really helpful for a lot of people. We have a big problem with them in the field with Narcotics Anonymous, because unlike Alcoholics Anonymous and Hazelden and Betty Ford and ASAM and the American Medical Association and the federal government, they don't consider medications for addiction treatment to be consistent with sobriety. Only Narcotic Anonymous says people should get off their methadone and buprenorphine. It really, medication for addiction treatment isn't really controversial for any professionals in the field. We would not pay, we would in 1965, but we would not for many decades pay for a hospital where a person went in psychotic and depressed, hearing voices telling them to kill themselves, and say, we don't believe in medication. Okay, not acceptable. Okay, we wouldn't pay for that. But we pay for that analogy in substance use disorder treatment. We need to stop paying for that. That's not appropriate. That is not appropriate medical care. Okay, we need to treat this the same way we do other conditions, instead of shoving this off in the corner like a social problem that people need to just get their act together and find their better spiritual core. Not that spiritual work is not important for anybody dealing with a chronic illness, because it's helpful for anybody dealing with a chronic illness, but it's not the core of treatment for any chronic illness.
All right. I think that's all the time we have. So thank you so much, Dr. Clark. That was super, super fascinating, if also depressing at times. But sometimes there are things that you need to be a little depressed about if we want to make the world a better place. So thank you so much for taking the time to come speak with us. As Dr. Myers was saying earlier, the student responses to our discussion questions will be sent to you as well, and you can sort of see some of that discussion. But thank you so much, and that should conclude our seminar.
Thanks. I appreciate the
Thank you.
opportunity to speak with you.
Yeah, thank you, Dr. Clark, and thank you, Dylan, too, for a great job. And we'll look forward to seeing you all next week.